the remaining time, I kind of like to take that future look. And so for both of you, in 5 years, as we see with 25, 35% of the pipeline being oral, where do we see, and orals becoming, because we have value-based care, we have clinical pathways, we've got this shift in terms of risk being borne more at the delivery level, so whether by the provider in the community or the hospital, what role will that insurance company play in that process? But I kind of just a capsule of how I think it may look in 5 years. So who wants to go first?
You got the easier
Okay.
task.
Well, I would say, you know, the cool thing in my career, and this is one of the reasons I became an oncologist, was, you know, I wanted to see incurable cancers become at least chronic diseases, if not cured. And clearly, the first steps to understanding that is to understand what makes a cancer cell a cancer cell. And now that we've done a good job of you know, starting to understand the pathways, now the work, of course, is developing targets to hit the appropriate driver mutations. And you know, in all likelihood, based on what we know now, we're going to need at least one, if not more than one, expensive drug, whether it's an oral oncolytic or immunotherapy or a combination thereof, or used in sequential therapy. So clearly, you know, as we know more and can do more, the cost of care is going to continue to skyrocket, and trying to control that spend is going to be a major challenge.
And as a community provider, does community medicine survive this? In order to manage that kind of cost, does it portend the end of community care and a shift to large institutional settings where they can risk bear for these very high cost treatments, or do you see? I mean, how do you see that weathering of the storm for community oncology, given that vision?
Yeah. First of all, I always say private practices are not insurance companies. So I mean, we can only take a limited amount of risk. And you know, kind of how these costs are ultimately managed, I think has yet to be determined. But you know, clearly there is a role, you know, for the oncologist in that management, which is, you know, he or she or the person on the front lines. They're having the face-to-face discussion with the patients. You know, they understand that patient's disease and comorbidities and that patient's wishes. So again, I think the incentives for that physician is to do the right thing, but yet the cost-effective thing. And I think that's where we're moving with these new risk-sharing models and value-based care models from the private payers, as well as the oncology care model from CMS.
All right, so you thought that was the easier of the answers. Where do you see it?
Well, I think for the last decade or more, we've been doing experiments to see what works. Medicare and CMMI is doing their oncology care model to see whether or not holding providers more accountable for cost and outcomes reduces the total cost of care. Ironically, I think I don't think we're going to reduce the total cost of care through drugs necessarily. I think it's using molecular diagnostics to drive out waste by not putting people on drugs that weren't likely to be effective in the first place. It's choosing agents that have equal efficacy but at a different cost. But even more importantly, it's driving out waste from ER visits, hospitalizations, providing care at the end of life that patients wouldn't have wanted had they known their option, better hospice and palliative care. I think the future looks bright for driving out waste, because I think everyone could agree that there is waste that exists in the system. I'm just not sure that it's going to be from drugs. But at the end of the day, we're looking for partnerships with practices, with systems, even with manufacturers around how do we improve oncology care and oncology care delivery. And in fact, with manufacturers, we're looking for purposeful partnerships where manufacturers take accountability for the outcomes of their drugs. Name one other area in healthcare where you get paid, well, there are probably a few, but manufacturers of devices, drugs, diagnostics today don't bear any accountability for their outcomes. And so should we be looking in that arena for partnerships where manufacturers are willing to take accountability for outcomes? And in fact, in the oral space, it works very well because they don't have the same Medicaid best pricing that you have in the infusible space.
Right. So you could see that since, give that first 14-day split fill being on the manufacturer, and only if they then refill.
Yeah.
Yeah,
I would agree. And some manmanufacturers have done that.
Right,
Yeah,
and then part two.
but that's not really a health outcome or a clinical outcome. Right. That's just, did they have toxicities, or was there some other reason they didn't fill the medication? I think we're looking more at did you achieve the results that you upon which your approval was based.
Right, although that gets harder, right? Because
Yeah.
they have to come to some consensus over what that is reasonable. Right?
I don't disagree. Yeah. This is hard work.
Right. How do you measure it and how do you report it? I think is going to be
I think our ability to measure outcomes has improved.
Right. It's both how to measure, it's when to measure, right?
And what the interval between how long are you willing to wait to measure an outcome?
Trying to distinguish between a drug effect and the biology of a disease can be tricky sometimes.
But I'm at risk for that today.
Yeah.
I'm at 100% risk for that today, regardless of whether it's the drug or the biology. And the manufacturer, at least I think, need to have some skin in the game in that space.
All right, guys, great. I barely had to say a word. On behalf of our panel, we thank you for joining us, and we hope you found this program informative.